So our next speaker is Professor Georgi Chaltikyan. I introduced him before, and Georgi is going to talk about building the digital health workforce, approach to digital health education and training, which is a very important aspect of digital health. Georgi, please add anything you like for information from you or for Deggendorf. The screen is yours, Georgi.
Thank you very much, Professor Fernandez Jefferson. First of all, it's a pleasure and honor to be again at Global Summit. Thanks for the invite. Thank you to the audience, of course, who are following these warm-up international, and thank you to the wonderful co-panelists. It's indeed an honor to be surrounded by such superstars. My name is Georgi Chaltikyan. I'm professor and head of digital health masters at Deggendorf Institute of Technology in Germany, at the so-called European Campus Rottal-Inn, and my primary focus is digital health education and training, as well as building the workforce and empowering the both professional as well as non-professional communities in digital health. In that regard, I have been also doing some consultancy for the WHO Europe, and a few of my remarks in this presentation will actually be based on the contribution that we provided to the one of the most recent World Health Organization toolkits on digitalization of health information systems that is due to be published in 2024. So there we co-authored a chapter on workforce development and capacity building. I would like just to, to set the stage, to quickly go through 2-3 slides that we commonly include in our keynotes about the transforming landscape through telemedicine that began as early as, in fact, it was pioneered even longer, even about more than 100 years ago, but began essentially actively used in 1980s. Then 1990s came the concept of e-health, then 2000s, of course, mobile health. And nowadays we obviously are using this umbrella term, digital health, focusing on smart devices, on Internet of Things, as Professor Ganapathy mentioned, big data, predictive analytics, AI, and eventually personalized medicine. And this is just to put all that graphically, how we imagine and recommend thinking about what is digital health as a multidisciplinary domain of knowledge and practice, which is based but not limited to the scientific disciplines of health and medical informatics, health telematics, and of course with some obviously interfaces with bioinformatics. And we consider digital health to be consisting of 8 subdomains, as we like to call them, that are listed on these slides, namely the digital health records and information systems, as well as the health information exchange. The second being telehealth, telemedicine, and virtual visits, personal health records, and patient portals, so remote care, basically, largely. The third one being all about mobile health, including the digital therapeutics, or as we call them here in Germany, DGAS. The next subdomain is everything about imaging and image analysis, then the augmented intervention and augmented visualization technologies such as extended reality, robotics, gaming, the subdomain of sensors, wearables, RPM, and ambient assisted living, health data analytics and AI, and eventually the digital biomarkers, omics, digital twins, and 10P healthcare. I'll come to it in a second. These 2 slides I can't help presenting or speaking a little bit about the perhaps 2 most important recent or current trends in digital generally, and in digital health as well. Of course, a little less than 1 year ago, in my opinion, we witnessed the revolutionary development, which we think will very significantly transform the landscape of artificial intelligence, as well as the specifically landscape of healthcare AI. And of course, I'm speaking about the launch or the entrance to global landscape of the most successful up to now, probably Gen AI or large language model, the ChatGPT. And here we can see actually that the developments in AI systems can no longer be considered even exponential. It's already, as we can see, vertical, the language and understanding. And here we can see the so-called zero benchmark, which is the level of human performance. According to one interesting piece published in The Guardian a few months ago, those are the factors that lead to the so-called combinatorial explosion, as the author John Norton noted. So we might be at the brink or already within the phase of rapid transformation and qualitative transformation, when those quantitative changes that have been accumulating in the past decades may suddenly result in this combinatorial explosion, including the factors like the availability of massive cloud computing power, the unimaginable quantities of data that are provided by the internet for training LLMs, the significant improvements in algorithms boosted by further developing neural networks, and as the author says, money provided by insanely profitable tech giants, with all due respect, obviously. And that all will, in our understanding, bring us closer to the future of digital health, which would be what I call the 10P healthcare. I know initially it was considered 3P or 4P healthcare, then some of colleagues call it 5P healthcare. The highest or the most I found in the literature actually was 6P. I permitted myself to further expand it to even 10 words, all starting in P, and this is what I refer to as 10P health. And each of these words starting in P, in my understanding and in my opinion, makes sense and makes important difference. Predictive, preventive, personalized, precision, participatory, pertinent, proactive, pervasive, permanent, and platform-based. And this, in my understanding, is all going to be evolving around the common platforms for collecting, analyzing in real time, obviously with the use of artificial intelligence, because the humans will no longer be able to analyze or make sense of all that data, obviously, health and wellness data coming from sensor-based devices, the person-generated health data, from genetic data, from self-reporting of health information, from EHR and other provided data, from claims, from ambient data, from social activities, behavioral, emotions, and others. Now, all that revolutionary transformation will be absolutely impossible without skilled and competent workforce. And not only workforce, but the workforce is definitely is a vital component of a digital health ecosystems and of digital health systems. And with digital transformation of healthcare, the traditional roles of the health workforce will also need to be transformed. As an example, as previous speakers have shown, there's a lot that should be and can be and should be and will be performed remotely and online. So there will be a paradigm shift, and there are already some doctors that are essentially trying or thinking digital first or remote first as the first option. And this is what we essentially refer to as the culture change, culture transformation, which is important and which is the cornerstone of the so-called digital transformation of healthcare. Because digitalization is still not enough. We're speaking about culture transformation, and the culture transformation which should be also supported by the commitment of the leadership and regulators and authorities and the public. The health workforce is thus positioned at the critical stage to enable the digital transformation. For countries that aim to digitalize their health systems, the health workforce at large face challenges such as the lack of knowledge, skills, and motivation to work with digital tools. And these challenges affect the attitudes of health workers, making it more difficult to adopt digital tools and innovation. A few years ago, a HIMSS survey, annual HIMSS survey, that was based on the feedback from 537 e-health stakeholders, revealed that one of the main challenges is the number of sufficiently skilled workforce, sufficiently skilled employees, as you can see it in this table. So what are these knowledge, skills, and competencies groups that need to be brought to the workforce, and not only to the workforce, and about that I will tell about that in a minute, in order to support the digital transformation. Digital health is obviously a uniquely interdisciplinary domain of knowledge and practice. It is based on knowledge and scientific disciplines within the domains of medicine, health, healthcare sciences, within the domain of computer science and information science, as well as from the domain of business administration and management, to name just the three most important. And the scope of the so-called KSC mix, as we like to call it, the knowledge, skills, and competencies mix, are including but not limited to medicine and healthcare delivery fundamentals, including healthcare research, computer science like databases, networks, software, as well as data and information management, the development, deployment, and management of digital solutions per se, including health information systems, mobile health applications and digital therapeutics, telemedicine, telehealth, wearables, biomarkers, health data analytics, and AI, and skills and knowledge that are necessary for evaluation of digital tools and systems with regard to their effectiveness, efficiency, data protection, regulation, and of course, ethics. So in our work for this chapter on developing digital health workforce and empowering the societies to embrace digital health transformation, we have gone ahead and defined the three user groups of the digital health system. This is based off of the previous work on e-health workforce development at the WHO some years ago, actually about 10 years ago already, where the authors of that previous compendium have already subdivided or defined two major roles and two major user groups within the workforce. Back then they still refer to it as e-health workforce. And group one being the health ICT workforce. And these are we refer to as DHIS professionals, or digital health information system professionals, including managers, administrators of digital health systems, strategic developers, information managers, informatics specialists, technical staff, data protection specialists, data specialists, ethics specialists, assistant staff, to name, but most important. Just the most important. Of course, there is also more roles, which obviously we were unable to present here on slides. The group two refers to health workforce, which means these are healthcare professionals, workers that are not themselves engaged in developing and maintaining the digital health systems, but are obviously the active users of the digital health systems. And those are basically all other health professionals: physicians, dentists, nurses, allied health workers, support staff, including the assistants, nursing assistants, and others. And then, in line with the most recent paradigm and the development of our understanding, conceptualization of digital health, which is impossible without empowered citizen, we introduced it as a separate third user group, including the citizens, the patients, basically all of us, right? Families and informal caregivers. Then for each of the user group, we suggested and we defined 6 dimensions of development of that user group, how to evaluate and approach that development. Number 1, the description of the user group per se and their possible roles. Number 2, the required KSC mix of the user group. Once again, knowledge, skills, and competencies. Number 3, a checklist for the current state of play of that user group. Then needs assessment for education, training, and development of the user group. The approaches to facilitate education, training, and development of the user group, basically the approaches to this workforce or population empowerment. And lastly, challenges, risks, and mitigation. On this slide, we will just demonstrate several types of different education and training offers that could be used in relation to each of the user group. So type 1 is most suitable for the user group 1, and this is, in our understanding, best achieved by formal degree-based education as bachelor, master, and even PhD programs in digital health. Type 2A is the integrated or built-in courses, in our understanding and in our opinion, and this is our vision, that there should be no medical or nursing or allied health curriculum starting now, not even now, yesterday, without built-in, embedded digital health courses, of course. 2B would be the standalone or add-on courses that should be designed and delivered to those who have earlier completed their medical education and training. And finally, type 3, relevant to the user group 3, are ad hoc and on-demand various education activities for the general population, including information portals, community-based trainings, in-app training, video-based training, gaming, patient education apps, awareness campaigns, and information dissemination. And of course, as we progress more into the era of extended reality-based trainings. My key messages here are on this slide. The digital transformation of health system will require significant workforce development efforts. Without building these competencies, building awareness, promoting adoption, promoting embracement of digital, that transformation will at least not be happening as fast as we would like it to, but most importantly, it will not be devoid of significant risk. So the primary goal of this education development is not even to support the transformation. The tsunami is coming. It will be coming whether we want it or not. But the most important is to make that future arrive on us in a safe and efficient way. With wider introduction of this technology, we will be seeing the emergence of at least 2 roles in the workforce: the digital health professionals per se versus health professionals that are working digital. It is important in our understanding to define and recognize these roles to facilitate the digital transformation. The knowledge of the current state of these workforce requirements, education approaches, and risk and challenges are crucial in building this capacity. With the increasing impact of digital health, the citizen is becoming as a central partner, contributor, and eventually probably the driver of these 10P healthcare. And the strengthening of all these 3 user groups is a key prerequisite for transitioning to the digital health system. Lastly, in 2 words about what we actually do. It's our Master of Digital Health, the program that we established 8 years ago, which has become probably one of the successful education offers, degree offers in digital health. We're also doing quite significant, or attempting at least, to streamline and harmonize the developments of curricula and the development of approaches towards digital health education and training. And we would be most happy and honored to collaborate with other educators and institutions active in that. We also feature our series of digital health events I hope, Jefferson, your audience would not mind, and you, of course, would not mind. I know you wouldn't, that we also present our digital health international series. Please check the website, the DigiHealth Day. Our symposium is coming up soon before the Global Summit. So everybody is most welcome to attend, also online, and to hear from as well major, brilliant opinion leaders and top experts from around the world. On that, obrigado, and thank you very much once again, and thank you for listening.
Thank you very much, Georgi, for your wonderful presentation as well regarding the situation that we have now with this tremendous digital transformation and the need of professionals and also citizens to be educated, trained, and it was nice this classification that you presented and the strategies of actions that could be done for these three different groups of two different groups of professionals and one towards citizens, which is very important. The digital literacy is one aspect that is coming very strongly in need to be developed. And also, I reinforce your invitation for people to participate in the digital health day in 10th of November, which is became a very important meeting globally for this field of digital